Hello YouTube, my name is Stefan Hartman, physician assistant, exercise science specialist, and health coach at ironmedicinepa.com. I'm beginning here my 3-part lecture series on glucose variability, also known as glycemic variability, in type 2 diabetics. This is the first part of the series. We're going to be going over what is glycemic variability and why it's important and some common drugs that may be used to control it. So, glycemic variability has come to attention most recently because of diabetes and COVID-19. And we're noticing that patients with poorly controlled diabetes have a higher mortality rate. And perhaps not only just poorly controlled diabetes, but specifically glycemic variability or glucose variability. Now, this may be important because COVID-19 causes a large inflammatory reaction and cytokine storm and cascade. We know that these patients who have these fluctuations of blood sugars throughout the day have similar amounts or parallel amounts of inflammation and baseline cytokine reactivity. And basically, the arteries don't like this glycemic variability. So that's potentially why these patients are at greater risk for having worse outcomes when you add on another inflammatory condition such as COVID-19. It's also been recognized as an independent risk factor for cardiovascular mortality. That is glycemic variability, an independent risk factor for cardiovascular mortality. So this is quite significant and potentially something that we can control. The standard diet on glycemic variability, this is a small study here, but they had 11 diabetic patients and 11 normal glycemic patients. The significance of the study is that they use CGMs, so continuous glucose monitors. Now, these are little systems that you can put on the back of your triceps, on your abdomen. They have these little tiny microfilaments. It's a little poke. You don't even feel it. And you wear this thing for about 2 weeks. You can get a good use out of it if you clean your skin really well. And it tracks in real time your blood sugars and downloads it onto an app, and you can review it with your medical practitioner, your local PA or local physician, and figure out what is causing your glycemic variability. Say you keep a diary and you note that you had this for breakfast and your blood sugar shot up to 300. Well, you make a note of that. So it really empowers a patient to make real-time changes and real-time recognition of what is causing their blood sugar to spike. So what they found here is that on the evening prior to the 24-hour analysis period, all subjects received a same standardized meal. So they did eat a lot of carbohydrates, 60% of energy from carbohydrates, very low on protein. The following day, the subjects were instructed to ingest their designated meals, drinks, and snacks at set time points. And throughout this 24-hour test period, subjects got the same amount of food, basically. They were tracked. Now let's see the graph here. Really cool graph on the CGM. And they're seeing huge spikes at breakfast with their morning breakfast, morning snack. And then it kind of dropped off a lot and it spiked up again. These obviously would be the diabetic patients. So for those not familiar with these numbers, 5.55 millimoles per liter, that's kind of what they use in Europe and Britain, is equal to about 100 milligrams per deciliter, which we're a little bit more familiar with in the US. So you can see these patients are really spiking up quite a lot in the diabetic population, perhaps in the 400s, 500 ranges, while the normal glycemic patients, they did spike a bit, mind you, but they kind of stayed relatively the same. So perhaps even for normal glycemic patients, so healthy patients like people like me, maybe we should be eating 60% carbohydrates and 12% protein. I don't actually do that myself. So so that's interesting. So doesn't Metformin prevent this? So many people are on this drug. It's a very cheap drug. It's a relatively safe drug to use. Many people have been using this for many, many decades. The present study shows that under normal standardized dietary conditions, patients with type 2 diabetes using oral blood glucose lowering medications experience a substantial amount of hyperglycemia for more than 13 hours within a 24-hour period. This disturbance in blood glucose homeostasis is predominantly present following breakfast. So, after comparing the 24-hour blood glucose profiles between the healthy, normal controls and the diabetic patients under care of a general practitioner, it seems clear that standard treatment schemes with oral blood glucose lowering drugs appear to be insufficient. So kind of a shocking study to see this in real time. So these patients were treated, they were diabetics, massively uncontrolled blood sugars when they ate this large carbohydrate meal. I would say even for the normal glycemic controls, they had, I wouldn't say not insignificant spikes in blood sugar. So continuous glucose monitor as a better marker than fasting plasma glucose and A1C. Now probably everyone listening to this has probably had a fasting plasma glucose as a simple blood draw and an A1C. They're cheap tests. Now CGMs are a bit pricey right now, but I'm hoping that we see these become cheaper in the future as they become more ubiquitous and more understood, that how powerful these are at empowering patients to understand the real-time ramifications of what they're eating and their the drugs that they're using to control their blood sugars. Maybe they're not. The A1C is a marker of, it's an average of your blood sugars over time. That's why we measure it. It's a nice little thing to use, but it's not ideal. And the fasting plasma glucose is also not ideal. I mean, if you're severe diabetic, these things are going to be high, but you can see in the normal glycemic patients, even in this trial, they did spike their blood sugars with meals, so that might be empowering for some people. But my A1C is 7 and my fasting glucose is normal. So consistent with previous studies, our present findings emphasize the need for different types of interventional strategies in type 2 diabetics. It should be noted that there was a weak, non-significant correlation between fasting plasma glucose and the percentage of hyperglycemia. The latter indicates that fasting plasma glucose is unlikely to be of sufficient sensitivity to successfully evaluate new treatment strategies that focus on reducing postprandial hyperglycemia. For more long-term evaluation purposes, changes in blood hemoglobin A1C concentrations have generally been assessed, since HbA1c content correlates relatively well with both mean 24-hour and postprandial glucose levels. So yeah, it's a great test to use. Should we mention here that even under clinically acceptable A1C levels, so less than 7, in 6 out of 11 patients with type 2 diabetes, hyperglycemia can still be unacceptably high at 11 plus 2 or minus hours of blood glucose excursion in 24 hours. So it is quite significant if we really understand how powerful and damaging a glycemic variable patient is, so to their own arteries, to their own risk factors for cardiovascular disease and death. So this is a really cool interventional study. Now, let's see what else we have here. Pharmaceuticals on postprandial glucose. So we're going to talk about a few pharmaceuticals that some people may or may not be aware of. So this is an Acarbose. So Acarbose is not used very much in the U.S., and mostly because it causes a lot of flatulence and diarrhea. But what was the results here? So in these patients using the Acarbose, a significant reduction in the progression of IMT, which is intima media thickness, so thickness of the arteries, was observed in the Acarbose group versus placebo after an average time of 3.9 years. So that was pretty cool. Acarbose slows the progression of the thickness of the intima media in impaired glucose tolerance subjects, a high-risk population for diabetes and atherosclerosis. This is the first placebo-controlled prospective subgroup analysis demonstrating the counterbalancing of postprandial hyperglycemia may be vasoprotective. So this was looking at that postprandial blood glucose spike, and Acarbose was helpful at lowering this. And it also, the study showed how important it is to control that spike of the blood sugar after the meal. Metformin is cheap, so how best to use it? post-meal exercise. Now we're going to go into this in other lectures, but this is a bit of an intro to this. Postprandial glucose excursions are highest in the morning, suggesting that breakfast might be the optimal meal for intervention. The purpose of the study was to examine the independent and combined effects of post-breakfast exercise and metformin monotherapy on peak postprandial glucose excursions. So findings from the study show that a combination of metformin monotherapy and moderate intensity post-meal exercise led to beneficial reductions in the postprandial glucose excursions. So that's a pretty cool. We're going to talk more about the exercise and nutrition aspect of this, but this is a little intro to that. So glycemic variability, should we and can we treat it? The Lantus metformin, the addition of bedtime insulin dose failed to modify the acute glucose fluctuations from peaks to nadirs, whatever the type of insulin used, long or intermediate acting. This is quite shocking. That statement is very shocking. So can we prevent glucose variability by using glucagon-like peptide 1 agonists? So Trulicity, Bydureon, Ozempic, these kind of a newer type of drugs. They're usually seen in pen form, and you can inject it subcutaneously, so underneath the fat, and you can get kind of a long, they're used for a week, but you can get this long reduction in blood sugars, so potentially limiting the amount of glycemic variability in a patient. So they looked at suboptimally controlled patients with type 2 diabetes who were further treated with once daily injection of insulin glargine. This is a longer acting insulin. So Hein et al. Observed that the changes in A1C and glycemic profiles were similar to those obtained by someone else in the Lantus study. In Hein's study, the glucose variability was not quantified, but the glucose fluctuation seemed to remain unchanged from baseline to endpoint in the glargine-treated group. In the second group, i.e. patients who were treated with Bydureon, which is a GLP-1 injection, I also found that improvement in A1C was the same as in the glargine-treated group. However, compared with the insulin glargine group, and everything else being equal in terms of glycemic disorders, the exenatide group, which is the injection form, exhibited less glucose variability at endpoint. So as in the Lantus study, the magnitude of glucose excursion was not quantified. However, by reading the crude differences between postprandial peaks and interprandial nadirs, as on the mean glucose patterns, it seems that glucose variability was reduced by 50% in the exenatide group, which is the injection form, the long-acting injection form of these new diabetic drugs such as Bydureon, compared to the glargine group. Such data suggests that the implementation of treatments aimed at reducing postprandial excursions is certainly a valuable strategy for reducing the parameters that characterize dysglycemia of diabetes. So let's look a little bit more at that. What do these things look like? Here's a couple pictures I have. So this is Bydureon. This is Trulicity. This is also generic is exenatide. And I believe this is the generic is dulaglutide for Trulicity. And this here is the insulin action curve. So we have glargine, which is the traditionally longer acting diabetic insulin therapy. We have the rapid acting ones. We have the Humalog, the Lispro. This one rapidly lowers blood sugar. They use this in the ER sometimes. Some patients are on this, but if we consider how important glycemic variability is, we potentially have to question the benefit of using rapid acting insulin as a daily usage. So discussion on GLP-1s and glycemic variability. So they did a study called the Flat Sugar Study. It was a 26-week follow-up trial in which patients were randomized to basal bolus regimen, which is your standard. You put insulin, lowers the blood sugar, and you keep on doing that throughout the day. When you check your blood sugar, you see it's high, bam, you hit yourself with the insulin, it drops it. So this obviously is going to cause a lot of glycemic variability fluctuations. So they randomized the patients to basal bolus regimen or basal insulin combined with daily exenatide, which is also known as Bydureon, every 12 hours. Patients with Bydureon presented less glycemic variability at short-term period in comparison with those with the basal bolus regimen, which would make sense if we believe what Bydureon does. So in the sub-study of Award 4, which was performed firstly in the 26 weeks period and that was expanded to a 52-week follow-up, Interday glycemic variability was significantly reduced in the group receiving Trulicity and Lispro insulin compared to those receiving the basal bolus regimen. Measure of glycemic variability, such as a standard deviation, was significantly reduced with Trulicity. So really cool stuff. I really like these new drugs. They are a bit expensive and sometimes insurance doesn't want to cover these, but I think they're great tools to use for the diabetics when we want to control for glycemic variability. So conclusions, glycemic variability is an under-recognized and critical factor in preventing mortality and morbidity from COVID-19, and it is an independent risk factor for cardiovascular morbidity and mortality. Standard fasting blood glucose and A1C are inadequate to monitor for glycemic variability. The CGM, also known as the continuous glucose monitor, is a useful tool to monitor for glycemic variability, and I think is a useful tool for any person, even a non-diabetic, to empower themselves with knowledge of how their blood sugar is acting in real time. Metformin, while useful for many reasons, may not control for glycemic variability. Acarbose, which is a pretty cheap drug not used in the US because it causes a lot of flatulence, can help with glycemic variability. And GLP-1 inhibitors, such as Trulicity and Bydureon, are more potentially useful drugs in helping to control glycemic variability compared to basal bolus insulin. A standard diet with 60% carbohydrates, 28% fat, and 12% protein, I wouldn't say is fine for non-diabetics. We can see these people even spike their blood sugar, and it will cause about 13 hours of glycemic variability in the diabetic patient. So quite harmful, I'd say. We're going to talk a lot about nutrition in the next lecture, and we're going to talk about exercise too, and how we can use that to control for postprandial glucose spikes, and how we can just control our blood sugars better with exercise in general. So these will be the two follow-ups, exercise. I might flip that around, so stay tuned. We might do diet first, but we'll see. I hope you guys enjoyed this lecture. As always, you can find the link to this slide and look at all the sources for yourself and read up on them. I highly recommend you do that. Share this with a diabetic. Share this with your primary. I want this message to get out. Understanding for glycemic variability, how important it is, how we should be controlling for it, how it is in the realm of possibility. Talk to you all next time.